Initiative and Foundation, which I am the CEO of, Jen Kovich-Bordenik. We do these executive forums several times a month where we bring together stakeholder leaders from across different spheres of influence. So public health, payer organizations, provider organizations, vendor organizations, data organizations, patient organizations, to really try to convene leaders together to talk about some of the core critical issues going on right now and share best practices. So to help people kind of understand what works and what doesn't work and create a safe space for you to discuss with each other those things. We are going to record this session today, and I want to tell you why we're recording it. We want to pull together kind of some of the highlights from the conversation today and some of the learnings, and put together kind of a brief following today's session about some of the great examples we heard about what's working. We do not intend to quote anybody here by name, so I do want you to feel open to being honest and genuine and sharing, you know, what's working and what's not working. Ask the questions that you want to ask of each other, but let you know that that is why we're recording today, so that we can get a transcript and put everything down on paper for you. But I think that, you know, the topic we're talking about today, so eHealth Initiative is a very, we're a small nonprofit organization in Washington, D.C., celebrating our 20-year anniversary. And we are a group of healthcare and technology leaders from around the country that are trying to address the most critical issues right now. And the 4 core issues that we look at as an organization are social determinants of health, privacy, COVID practices, and virtual care. And those are the topics that we gather around. We do research, thought leadership around, surveys, etc. And because you're here today, we've invited you here today because you've been recognized as a leader in this area or somebody that we want to hear and learn from. And we've got a really great group of folks gathered here today, and it looks like we've got everybody here. So I do want to kind of jump into the agenda just slightly here. We're going to keep you on camera when we do discussions, when we're doing kind of, we've got a couple of different presentations throughout the day today. The purpose is really to get you guys talking. So the presentations that you're going to hear are really meant to be a kind of a springboard into your questions and comments. And we want you to speak as much as possible. We want you to raise your hand, jump into the conversation. You should all be able to be, to unmute yourself. You should all be able to be on camera, and that's our intention. We'd like you to stay on camera as much as possible and unmute yourself whenever you have a question here today, because we want, again, really genuine conversation, honest conversation, and that's what we're known for, and that's what we're trying to promote here. So again, I'm Jen Kovich-Bordenik. I'm going to turn it over. I do want to thank LexisNexis. As I mentioned, we're a really small organization, so we rely on the support and generosity of organizations to help support our education efforts. And LexisNexis, who's been doing a lot of work in this area, agreed to help us today with the program. So I'm going to turn it over to Diana in just a minute. Before we do that, I just want to share with you a little bit about the organization and what we're doing. I've given you a little bit of background, but Sarah, if you could, or who's running the slides here? 1A, Sarah? Yeah, so I just talked about that. We do education advocacy and thought leadership. There, this is what I'd like to show. So as I mentioned, we work with a number of companies across the country. This is just sampling of the different executives that we work with. And again, our intention is to convene leaders that don't usually work together, but are all focused on these really critical issues. And I think COVID-19 and what the states are doing in public health is really important. Particularly now that we're talking about social determinants of health. And you know, this year's really given us an opportunity to, we were on a social determinants of health webinar yesterday, and somebody said, you know, the one thing that COVID has done is really done our job for us in terms of educating the public about why these things are important. And I think, you know, if there is a silver lining to COVID, it is that I think, you know, the general public has a much better kind of understanding about social determinants of health, why some of these factors are important to care, what the detrimental results can be. So that's something that we wanted to do today, is we wanted to share some examples of what states are doing. If you go to the next slide. I already mentioned here, so these are the critical issue areas that we're working on. If you go to the next slide. Okay, and as I mentioned, so we do a number of these forums every month. Some of them are open to the public where we do large webinars, but we do a lot of these small, we call them virtual roundtables, with really just selectively invited folks such as yourself to really try to drill down a little bit more into some of these key areas and have a deeper conversation. And that's really our intent today. We do try to publish kind of highlights from conversations. We will try to share slides if possible. If the speakers allow us, we will share slides. And if there are any kind of key presentations today and the speakers feel comfortable, we will share those presentations after today as well. But our intent is really educational and to form a greater consensus and understanding of what's happening. Next slide. I do want to share with you, we've done a lot of work on social determinants of health this year. Just to give you a little bit of background about eHealth initiative. Last year, we came up with guiding principles for the ethical use of social determinants of health data. And we did that with a very broad stakeholder group. Trying to really understand, there was a lot of concern about discrimination and how some of this data could be used against people. And so we wanted to really kind of set the ground rules for when this, why this, data is important, why it should be used, and kind of clear examples of when it should be used. So we have published work in that area over the last year. The other thing we did was we've looked specifically into certain communities. We did, and we will continue to do actually throughout this year, a significant amount of work about supporting American Indian and Alaskan Native communities combating COVID-19 and how to use social determinants of health in that world as well. And we're starting to look at SDOH around research in pharmaceutical and clinical trial development, particularly with the rollout of the vaccines. And how that can impact it as well. So this is an area that our organization is really very concerned about and trying to learn more about so that we can share it. So I just wanted to share that with you so you can learn a little bit more about what we're doing. Next slide. And this is just some upcoming programs that we have. Go ahead, next slide. So I would just ask that you mute yourself when you're not speaking today. I do actually want you to keep your cameras on if you can. As I said, I want you to feel, I think when your camera's on, you're more likely to ask a question. So ask questions, jump in. We've got an incredible slate of speakers and presenters today. They're not meant to be the only ones. You guys are here because we want to hear from you. So please jump into the conversation. If you have an example of how something's working or not working at your organization, feel free to jump in. I know we had a call with all of our speakers a day or so ago, and I know that they're all really anxious to hear from you as well. So I just want to, again, encourage you to do that as we get into the conversation today. Go to the next slide. And again, I want to thank Diana and LexisNexis for supporting our little nonprofit and helping us with this program today. So thanks. And I'm going to give Diana a chance as well to talk a little bit about it and kick us off a little bit. But I know she's got a great case study that she's going to jump into as well. So Diana, why don't I turn it over to you?
Thanks so much, Jennifer, and thank you so much for pulling this together. We are so excited to have all of you gathered together. I know it's hard these days with back-to-back Zoom calls and, as Jen mentioned, all the disruption going on. I know how hard it is to get time on the calendar in January. It feels like every single thing that you put off before the holidays is suddenly a deadline. So again, just want to thank everyone for their time and their participation. I, again, really thank you, eHealth, for having us and for pulling this together. I think we've been really excited, particularly to get this roundtable together of government leaders. I know eHealth has hosted, and we've all probably attended many conversations about social determinants of health, and gotten a lot of perspectives from people, on the ground, providers, case managers, payers. But we felt like, given everything happening in the country between COVID, health reform, a new administration, and as Jennifer mentioned, kind of an added understanding of social determinants, really wanted to get government leaders together to think about what the role is of agencies in this complex kind of response. And I know Juane's got the slide up here of all the speakers. I think we're really excited. I know I'm going to share some trends and best practices around data. I don't want to spoil any of the other presentations, but I think Melinda's got some really, really exciting trends that from a policy and contracting perspective on the Medicaid side that I think will dovetail really, really well into the conversation. I'm personally a little bit biased for Amanda's presentation because I'm a former North Carolina Tar Heel. So excited to hear about the work that Amanda's leading in North Carolina. And also thank you to Rob Bossart from the VA, who's going to be sharing his research that actually leveraged some of the LexisNexis data that I'll be talking about as well. So really, really excited. And again, please chat or put your take yourself off mute to pause and answer any questions. Juane or Jen, any other kind of housekeeping things before we get started?
No, I think we're set to go. So if you want to jump in.
Awesome. So I'm going to actually kind of take a step back, and I'm going to kind of give my personal bias to this topic a little bit. So my background is right at the intersection of public health and Medicaid, and looking at the bio book, I think a lot of you kind of come from similar backgrounds, and understanding that, in the public health space, we've been talking about social determinants for a really long time, but never really quite, getting to that actionable point. I think on the Medicaid side, it's been very clinical focused, but more and more, as Melinda will talk about, momentum for social determinants. But one thing that, for me, I kind of coming from the public health and Medicaid sector, joined LexisNexis about 6 months ago. And so in my personal kind of 2021 planning, have been doing a lot of thinking about the role of data. And I was thinking about how often in public health we talk about, or in Medicaid, in healthcare in general, we talk about whole person care and patient-centered care. But then when we kind of get to the data, all of a sudden it becomes, oh, this has to be aggregated, or we're looking at a zip code, we're looking at, a population health approach. And so, one of the things I want to talk about today and kind of put out on there on the table is that whole person care, or kind of the idea of matching the social with the clinical and the behavioral health all together really starts with having whole person data. And I just came up with that. I don't think that's an official term. So if someone has a better term, please chat me and let me know. But I want to, kind of tell you a little bit about the data that LexisNexis has and how some of those non-traditional data sources might actually kind of help you think about social determinants. And then I also want to share some trends that we've got, that we've seen across states, and want to get your feedback on them as well. So if we can go to the next slide. I think actually if you can click again, I didn't realize this had animation built in. For those of you who are not familiar with LexisNexis, I boiled down really into 4 slides today, so I'm not going to go into a ton of detail, but I did just want to give you a little sense for sort of what we do for government healthcare, and we work really closely with eHealth, both with our government healthcare business as well as our healthcare business. So you may have also kind of encountered us on the payer and provider side. But essentially, if you think about this really robust, we have a very robust database of 78 billion public records, 10,000 data sources. And I could go through slides and slides and slides of what all of those data sources are. They're publicly available and they're also privately licensed. And I just chose some of the ones on here that if you're looking at the left of this rather busy slide, I wanted to kind of call your attention because as you're thinking about these, I'm sure you're like, oh, well, these, match up pretty well with social determinants, right? When we're thinking about vehicle registration, does someone have a car or access to a car? Criminal or bankruptcy records, what is going on in the person's personal life that might be interrupting their access to healthcare or their ability sort of to network with their social community? Property records, assets, cell phones, email addresses. So all of the attributes that would then kind of go into a person's address, where are they living, who are they related to, their personal income and legal status. And really what LexisNexis is an expert in doing is matching all of those 10,000 data sources down to the individual. And then we support state agencies with providing that data to support various initiatives. So today, obviously, we're going to be talking about social determinants of health. We do, as you can imagine, a lot of data management, and in many of the states and federal agencies that you all represent, we support, data hygiene efforts. We provide you best contact data or best address data, deceased data. We're supporting many states on contact tracing because we have data to show not only, what address someone gave when they signed up for benefits, but also what was the last address that they received mail at, what's the best phone number to reach them. So very, very critical information to manage COVID. Social determinants, which we'll get into a little bit today. And then of course, thinking about how that data can be used to support Medicaid eligibility, Medicaid program integrity, making sure the right people get into the program, making sure that the wrong people stay out. And then, I focused a lot on our consumer data and the 283 identities that we have around that. But the other really large portion of our data set is around healthcare providers. And so we, support almost, I think, every state that's represented on here in some way with our provider data and supporting, making sure that we're screening and enrolling the appropriate providers into Medicaid. So if we go into the next slide, I want to jump into the social determinants piece. And so as I mentioned, kind of at the first slide, I've spent a lot of time thinking about, and I think talking with a lot of state leaders over the last 2 or 3 years around this idea that zip codes, we've done a great job convincing the general public that zip codes predict health risk, and they really impact health disparities and socioeconomic disparities. But I think as you get the next layer down, what we're realizing is while zip codes make a huge difference, and they certainly matter, I'm going to kind of say the controversial statement here, they don't tell the full picture. And so, this is a case study, kind of an example of 2 Medicaid members. I think all of us have worked with these types of Medicaid members, right? You've got some young women, Alex and Lisa. Clinically, they look very similar. They both have been diagnosed with diabetes and depression. They live in the same zip code, which happens to be 77096 in Houston. I grew up there, just not all that creative. Alex has been on and off coverage when she was pregnant. Lisa's actually a new Medicaid member, maybe lost her job due to COVID. So clinically and demographically, these 2 women look very similar. And oftentimes that means that they're getting the same kind of care. But that, and we like to say, well, we're looking at their social determinant. We looked at the zip code that they live in, but that's not necessarily representing all of those additional data points below that. And so when we look at, Alex having recent bankruptcies, on owning a car, and being socially isolated, not having any relatives nearby, puts her at much higher risk for something like chronic depression and may need some additional chronic disease support compared to Lisa, who actually, owns a car, has a college degree, lives in a low crime neighborhood, near family, and maybe just needs some general kind of lifestyle education and support, but not a super intensive social determinant intervention. So I just wanted to kind of show that as an example of how zip code doesn't tell the whole story. If we go on to the next slide, I mentioned a little bit about, sorry, there's a little bit of a delay on my side. So I mentioned a little bit about the LexisNexis social determinants of health data. I did just want to briefly let you guys know what that looks like. And then, like I said, really spend some time talking about trends. Essentially, we've taken that, that data set I was talking about, the 280 million consumer identities, taken that data set and validated it against health outcomes. And then built that into 400 attributes and 32 care drivers. And so what that provides is really, really detailed data down to the individual level that can be used both as predictive models. And I think Rob will be sharing a little bit later on how some of those attributes relate to some of the modeling he's done, but also care drivers. I'm going to talk about that in a second, about how that really can make some of this data more actionable for your agencies and your programs. So if we go on to the next slide, wanted to share some trends and best practices. And please feel free to disagree or agree or share your own anecdote on any of these. The first one that we, at the top, the always constant problem in Medicaid, right? No clinical history. This is a brand new Medicaid member, or this person was a Medicaid member before, but we don't have a great way to match their previous claims history. This is where we're seeing socioeconomic attributes and some of our cost of care risk models, being able to provide a picture of that risk, and being able to kind of stratify the population, even if you don't have the clinical data, to be able to model out, again, some of that socioeconomic risk. The other trend that we're seeing, and what I would say is definitely a best practice, right, is getting data on day one and on day 100. And what I mean by that is, so many times I've spent about 12 years in the social determinants of health space, and we build these really, really robust programs, but they ultimately rely on someone coming into the clinic or to a screening facility to take a really long questionnaire. And that ultimately kind of widens the disparity. It makes it harder to reach the hard to reach. So the great thing about a public records-based database is you can get individual level data on the entire population on day one, and then kind of continue to follow that population on day 100, day 1000, whatever it might be, to also continuously see any updates or changes that you might not have gotten in that initial screening. The other best practice that we see is definitely utilizing care drivers. We've got many partnerships with states that are building, like North Carolina, very active referral networks, whether that's with Unite Us or Aunt Bertha or some of the other fantastic organizations. But how do you really match those referrals to the right person? The great thing about this data set is it does provide kind of the 3 top socioeconomic drivers, again, for each person. So Lisa's drivers are going to be very different from someone else's, depending on her socioeconomic, on those 400 attributes, kind of looking at, well, what are the top 3 that are driving that care? And then last but not least, my favorite topic as a public health nerd, measuring ROI, right? So having a consistent data set really levels the playing field for evaluation. It may, not necessarily be the end all be all for like a screening program, but it does provide kind of that, again, that data at day one, and then that data at the end of the program to really measure, how did things change based on programs that you set up. So those are some of the trends and best practices I wanted to share. I know we're really close on time, so I want to pause and see if there are reactions to this, questions, or any kind of discussion questions to jump off of these. I tried to keep it very short today.
Hey Diana, this is Chris Chen. I'm a medical director for Medicaid from Washington State. I think your kind of opening statement, I really like the phrase whole person data leading to whole person care. And I think the most contemporary example that we can find of that is just the vaccine distribution allocation. The framework for prioritization of the vaccine is contingent on criteria for which no single database captures all of the elements, right? So we're talking about healthcare workers and their occupation, individuals and their demographics, and their age, where they reside, whether they're in a congregate setting or not, their medical conditions and other risk factors, and even things like race, ethnicity, and no single database contains all of that. And providers have told us that they don't want to be held responsible for vetting whether or not an individual has access to this really kind of scarce and precious resource right now. And so we're kind of just resorting to self-report. And I think that there's lots of different data sources that people have used to try and kind of target allocation to specific communities. But that has, kind of still fallen short, and we're finding that different regions are moving faster on their phases than other regions. And so I think it just kind of speaks to the need for how we can achieve better whole person care with whole person data.
Yeah, great point. And definitely share your observation that, oftentimes that data exists, but there's just no way without a really robust kind of data management or master key to pull it all together, just because it's so varied. And one of the things, I probably actually had it on here, is the notion of matching social data to clinical data is still, I think, very nascent. And I think one of the good things coming out of COVID may be that we get better at that, but fingers crossed.
I had a question for you. One of the challenges that we're facing is trying to figure out how data systems across the United States do or don't track veteran or military status as a social determinant of health. Do you guys have any thoughts about that, or is that something that you've been working on in your data set?
Yeah, I know we have some folks on from the VA. I don't know if anyone wanted to address that directly before I do.
This is Ernie Moore from the VA. I do know that veteran status is included in some of the programs that exist outside. So for instance, I know many Medicaid programs will collect information about veteran status. And if that's flowing into your system, then that information should be there. Yeah. And Kate, as to your question of whether it's in our data set, let me get back to you on that. I'm not super familiar with it. I want to lean towards no, but I don't want to rule it out without checking with some others.
Okay, thanks. And I'm thinking not just the data that we get from the veterans that choose the VHA healthcare system, but veterans that are also not attached to a government healthcare system. Maybe through Medicaid would be the answer, but we're really trying to find some way to better understand kind of the universe, what's going on. So thank you for that.
Yeah, absolutely. And Kate, remind me, what agency are you with?
I'm with the President's Roadmap to Empower Veterans and End the National Tragedy of Suicide, which is a very long name, but it's the President's Executive Order Task Force, basically.
Got
so
it.
Thank you.
All right. Well, let's move on, and I want to encourage folks to keep jumping in. Thank you so much, Diana. As your thoughts and comments come up, again, we really want to hear from everybody around here, and the presentations are meant as a springboard. One of the things I'm really excited about is that we have Melinda here from Manat, who's going to talk about their recent report. When we were planning to put together this executive roundtable, we were really fortunate because I just looked out and there was this great report that had just been released on what's happening around the country right now. So I want to turn it over to Melinda, who's going to give you a little bit of a summary of what's in here. And I think actually we'll send, I don't think we've sent everybody a link to the report. 1A, maybe we can push that link out through the chat box so everybody can just have the report as well on hand.
Great.
Melinda Dutton, yeah.
Thank you. All right, so as Jen mentioned, we did this report. The data gathering happened through last summer. It was one of the many work products out there that I think many of us had the experience of toiling on something and then COVID hit and you're like, oh wait, does this matter anymore? And fortunately for this one, we actually think it matters even more. So what we did, and we can go to the next slide, please, is we, Manat, we work with a lot of states on a variety of issues related to their Medicaid and coverage programs, and specifically on initiatives to address social drivers of health or social determinants of health. And we tend to work with states who are more forward thinking, like North Carolina. Amanda is who's going to talk more about her work, and other states as well. But we really wanted to get a baseline of where Medicaid managed care programs are nationwide. And so we embarked upon looking at all of the Medicaid managed care contracts in the country and seeking to identify provisions that explicitly sought to address social determinants of health. And we ended up bucketing them into 6 categories: care management, workforce, data development, collection and evaluation, quality metrics and strategy, financing, and community initiatives. we clustered what we found into groups of common practices, emergent practices, and leading edge practices. The report itself dives in more deeply. Obviously, within care management or within workforce, there are multiple types of initiatives or contract requirements that states can and do include there. But I'm going to just give you some of the top lines from what our findings are. And then I'm going to turn actually to talking about how that relates to COVID and what we view as kind of some of the next steps or things to look for in terms of states deploying initiatives to address social drivers of health within their Medicaid and CHIP programs. So let's go to slide 3. So the top line here is that all but one of the states of the 39 states that we reviewed had at least one provision in the contract, in their Medicaid managed care contract, that explicitly directed the plan to take some action to address social determinants of health. And so you can see in this slide, the white states don't have Medicaid managed care. The orange state is the only one, North Dakota there, who has Medicaid managed care, but were unable to find any explicit reference to social determinants of health within their contract. And then the rest of the states all had at least one provision. The dark blue states are states that also have 1115 waivers that include explicit new flexibilities or initiatives related to social determinants of health. So you can see, it is at this point, it is the common practice and accepted by state Medicaid programs across the country that they need to pay attention to social determinants of health and that they need their Medicaid managed care partners to help them do that. So some of the most common practices we saw were related to care management provisions, and this makes perfect sense. Care management responsibilities, for social determinants of health screenings and those sorts of things to happen in the context of care management is exactly where they should be embedded. We saw workforce provisions in more leading states around requirements like around community health workers, like in Michigan and New Mexico. Many states also within their contracts explicitly identify high need populations that they direct the plans to target their initiatives at. We also saw that many states are explicit about what we call the domains or the types of needs that they want the plans to pay attention to, with housing and food access being the top 2 areas that states focus on. Let's go to the next slide, please. What we call emerging practices, that's where less than half of the states were focused on it, but still, more than 10 of the states were focused on it, were efforts to improve the ability to collect and report social determinants data and training for staff. So I think of these as kind of building block provisions. If we think of the kind of explicit recognition of social drivers in the care management context as the foundation, the next level up is really what are you telling us, managed care plans, around what those needs are and what you're doing to address those needs. How are you assuring us, managed care plans, that your staff knows what to look for and is actually integrating this into your practice? I will say that what we saw in terms of the contract language in these areas varies a lot. There's a number of states that are asking for information from the managed care plans. It's less clear what they're doing with that information and to what extent that information is actually informing policy by the state and or by the plan. So I think there's a lot of room for growth there, but I think it's significant that we saw this many states who are explicitly mandating contractual reporting in their managed care plans related to social drivers of health. Let's go to the next slide, please. And then these are our leading edge states, and we actually are fortunate on the phone to have a number of our leading edge states participating in the discussion today, but there are a handful of states across the country who are really, in a far more comprehensive way, seeking to address social drivers of health. They're having more sophisticated obligations in terms of exchanging information. We know that in order to be effective at addressing social determinants of health, we need to have the ability to exchange information between providers, between plans, and between community organizations who are often the service providers for the social service providers to address those drivers of health. They are integrating them into their quality metrics and reporting, sometimes often linking them to financial incentives or withholds within the context of the contract. They're leveraging payment and financing mechanisms within their Medicaid managed care contracts, like pre-approving in lieu of services, or encouraging or incentivizing the provision of value-added services that address social determinants of health. And in some of the most forward-leading states, we are seeing efforts to seed new types of collaborations with community-based organizations. In North Carolina, Washington, New Jersey, Oregon, other states, we see requirements to partner with community-based organizations and to create networks or hubs of community-based organizations that can help collaborate with managed care plans, and with the ultimate goal in a lot of these states of being able to bring these sorts of interventions to scale and create kind of sustainability in terms of the services and networks that can provide and address social drivers of health. So that's at the kind of the highest level, some of the takeaways from our survey. And this was all pre-COVID. So I wanted to talk just for a couple of moments about what we saw, next slide please, how we saw states building on these practices to address COVID. COVID was clearly devastating to communities, to state budgets. It created enormous challenges for our healthcare infrastructure. It's really tested both our public health and our healthcare delivery systems. One of the potential silver linings for COVID is it did force a new level of collaboration across public health, healthcare delivery, and across the systems that address social determinants of health. So we saw states, and I highlight Washington here, I know they're on the phone today, pulling together interagency work groups to collaborate in a new, in kind of a new way in terms of how they could bring the resources to bear that spanned across healthcare and social services resources to help people get access to testing, to help once people were identified as either exposed or positive, to help them with isolation or quarantine. The CARES Act dollars were incredibly helpful in terms of stimulating this, so that brought new resources to bear that enabled these agencies to come together and also to provide new types of services. They were less had less restrictions in terms of which pots of money are we pulling this out of, and we're freed up in some ways to do that. But what we saw as a result, and we can go to the next slide, is unprecedented integration of healthcare delivery and social services delivery, delivery of services outside of medical care that are specifically designed to protect health, in this case COVID, and prevent the spread of the pandemic. That it kind of goes to the heart of what the purpose of initiatives to address social drivers of health do. So for example, we saw states going towards, going upstream and looking at eviction as a risk factor for healthcare outcomes and issuing eviction moratoriums. We saw 15 states added coverage for home delivered meals to their existing Medicaid waivers to enable people to stay home, to isolate or quarantine, and ensure that they had food and healthy meals while they were doing so. And we saw a number of states launch collaborative programs between their state agencies and the private sector to help individuals get access to the social services and wraparound supports that they needed in order to isolate and quarantine. And Amanda's going to talk about one of those efforts today. I like to think of this as a trial run for what we really want to bring to scale on a larger basis across our Medicaid programs and CHIP programs, and frankly, Medicare and private coverage as well. This ability to integrate across the full continuum of care to include not just medical care, but the range of interventions that are necessary from an upstream perspective and at an individual perspective to address social determinants of health. Just we'll go to the next slide, a couple of thoughts to get the conversation going. And then I really would, looks like our formatting's off a bit, but really would love to hear, since I know so many of you are on the phone today are from states who have been deep into these efforts, would love to hear your feedback and thoughts. But where do we go next here? I actually really believe that the momentum that was already building prior to COVID and that really accelerated through COVID is going to continue. Obviously, there are state challenges. States have serious budget constraints in the year ahead because of the depressed tax revenues due to COVID and the economic crisis. But I think that we have accelerated and broadened the belief, the knowledge that addressing social drivers is actually central to healthcare outcomes and healthcare costs, and needs to be. We can't afford to not to integrate it into our healthcare strategies and our coverage strategies. We were already seeing an increase in the number and scale of interventions, and I would expect that to continue as well, including the diversity of those types of interventions. So, overwhelmingly, we know there's great evidence based around food and around housing. Many initiatives have focused on very high need, high cost populations within those domains. But we know, for example, ACEs are actually tragic predictor of and that's adverse childhood events, such as trauma, abuse, living in unstable environments, are an unfortunate predictor of higher healthcare costs, poor healthcare outcomes, poor academic achievement, even poor income over the lifetime. And we're seeing a handful of states really buckle down and look at the children and ACEs, recognizing that we aren't going to get an ROI on that in 6 months or 12 months or maybe even 2 years, but really seeking to go more broad in our populations in the way we think about our ability to address social drivers of health. 3, the health information challenge here is enormous, and Diana spoke about that. And I think we are seeing more creativity and more resources taking advantage of enhanced Medicaid funds, for example, to finance some shared infrastructure to enable data exchange and leverage digital solutions across payers and providers and community organizations. 4, this focus on ROI. We know that there's an emergent evidence base. This is important. I will also flag ROI isn't the only value to receive here. And I think along with the focus on ROI, there's a recognition that improvement in healthcare itself has value. And then finally, the growing interest in new domains and populations and the upstream factors, the recognition that racial discrimination itself is a social driver of health, and that addressing institutional racism, poverty, and education, the eviction moratorium example, that this needs to be more than Band-Aids, that we need to look more institutionally at how we affect these drivers of health. So let me pause there, and I would love to hear reactions from the states on the phone.
And if we could pull the slides down, Sarah or 1A, so we could all see each other for a moment, that would be great. And let's have a bit of discussion here. So let's hear from the states around. Does this sound right? Are you seeing the same thing? I mean, I think there's definitely been more collaboration, but I would love to hear from you. Feel free to jump in, anyone.
Hi, Jen. This is Stephanie with Colorado. This is a great presentation, and I think our experience would agree with that, and excited to hear about the states that are ahead of us in that too. And one thing that, well, many things, but one thing that we have been struggling with lately is how it's back to kind of that ROI. But again, more than that, because especially with the end of high tech coming in September, thinking about how do we position ourselves and our projects that we're working on to show that value and show that ongoing need for that funding. So that's one thing I'll mention. The other thing is, you know, I'm coming at it. I work for the Office of eHealth Innovation in the Lieutenant Governor's office, and we work very closely with Colorado Medicaid, but, you know, we focus a lot on interoperability and the technical solutions. And so one thing that we're focused on in our care coordination initiative is the social health information exchange, and, you know, bringing these different community-based organizations as well as new platforms like Gelada and Unite Us and all of those folks together, and not relying on just one of them to be Colorado's answer. And so I think those are kind of our two things top of mind for us.
Great comment. Other thoughts?
Hi, this is Gary Singh from Massachusetts. So piggybacking off of what Stephanie mentioned, we also have been trying to think through the electronic referral or electronic exchange of this SDH related information. And one of the pieces that we've tried to think through is we're a little too late in the game to come out with a solution like what North Carolina has, where Unite Us is like the entity, or, you know, Virginia, I guess, recently did something with Unite Us as well. So I think we're also struggling with this question of, if we were to do something that acknowledges the different systems that are in the state, what does interoperability actually look like? Because what are the data elements that you would be able to exchange between the networks that wouldn't violate, you know, various, whatever regulations that are out there. So I think some guidance or some briefs, or I don't know, some research on that area would be really helpful. I think one of the other things that we're thinking about is, so right now we focus on housing and nutrition through our ACO program. And getting to that point of understanding what are the housing and nutrition resources that are available in the state, that was a huge lift. And it's also a huge lift for our ACOs to learn about these domains so that they can appropriately find the community-based partners to work with. And so as we think about expanding or additional domains, that lift to educate ourselves about all the resources that are available is a very big thing. And so at least for us, one potential resource that could be helpful in the future is just some way to understand the litany of resources that are available, so that our Medicaid dollars are sort of the payer of last resort, as opposed to and then having that understanding so that we're not duplicating, but we're augmenting. Thank you.
That's a great comment. Does anybody have any suggestions for Gary, for, you know, others that are not late to the game, but just starting later? You know, how to deal with some of these issues? Any other states want to jump in here?
Well, Gary, I will say, oh, sorry, go ahead.
Sorry. So, hi, this is Karen from Illinois. So I run health promotion programs, and I really thought from a programmatic lens, what you were talking about was very relevant. I mean, we are currently working on a health equity checklist with regards to social determinants of health. So programmatically, really what we're trying to do is not just consider what social determinants of health means for urban communities, but also for rural communities in Illinois, and also for the middle class. Because I think that oftentimes we have this intellectual, rhetorical discussion that we're just talking about communities of color, when in reality we're talking about the diversity of communities throughout the United States and within states alone. So we're really working to address with local health departments, with community-based organizations, to really have more thoughtful conversations about what social determinants of health means within their communities, not necessarily what is prescribed. So those are my thoughts. Thank you.
Great. Chris, were you going to jump in here?
Oh yeah, I was. So Gary, we've been looking at some work that's going on in Oregon and Pennsylvania, kind of finding ourselves in a similar state where there's a lot of movement in the community that we have a pulse on a little bit through our accountable communities of health. But yeah, trying to figure out what is the role of the state. And I think Oregon, I think they're probably on this call, is doing this in a really nice way. And we've been considering that approach as well. Other just quick comments as far as it pertains to like social determinants and data, you know, we've got some interesting things going. We have like a Medicaid quality incentive program for the hospitals that requires them to measure 3 social determinants. Our MCOs kind of all do screeners, and we're working on standardizing that. We recently did a survey, and I think they all, between the 5 of them, they ask 70 different questions, only one of which is the same. And it's like, and it's, do you smoke? We're trying to get a little bit more standardization around that. I think these questions around social determinants quickly move from kind of like these very kind of data and standardization specific ones to the meta, like what is healthcare's role in addressing social determinants, and especially kind of given that we spend billions of dollars as a state on SNAP and TANF and WIC, and even as a Medicaid agency on transportation, we've been thinking as a state about social determinants even before the term was coined. But how, like, if, you know, given that pre-existing state, where is Medicaid going to fit in, and specifically around investment, kind of steering someone towards a resource, steering an individual towards a housing resource is very different than kind of acting on policy levers to like improve, you know, housing in the community. And so we kind of by nature take a very transactional lens to it. And so I think it's, those discussions have been happening a lot for us. And how do we engage with our other kind of partners in public health and DSHS and DCYF and kind of think about healthcare's specific role. And I think a lot of that also kind of just quickly also morphs to these societal questions in terms of like, what are we as a society willing to kind of invest in? Like, are we just more ready to invest in healthcare than we are in social welfare spending? Anyway, that's probably beyond the scope of this conversation, but maybe relevant.
We could talk about that all afternoon. And Gary, I know Stephanie had to jump off from Colorado, but she left her email there. She said she has a whole bunch of resources for you. So
I just pinged her.
Okay, great. Other comments, questions for Melinda? Melinda, this is an incredible piece of work, really, what you guys did.
Hi, Melinda and everyone. This is Paloma. I'm from the New York State Department of Health. So, you know, I saw your graph and I'm like, oh yeah, that sounds right. But I think, you know, it's also like how it's, as an evaluator myself, whenever I see myself evaluated, I'm like, oh, that doesn't sound exactly right. But it's not a bad thing. It's more like, I just know all the intimate details. So one, I think like, you know, New York State participated in a huge waiver program, 1115, our DSRIP program. And the whole thing was about transforming, you know, the conversation around quality and value through our PPSs. And like, I think Chris, you just said you had 3 managed cares, like we have 15. And then we have like 3 for HIV only. And we have 10 for special. It's a behemoth. So, you know, I think about where we were even 5 years ago and where we are now, and we're sort of milling around, you know, and giving nuance to the graph, nuance to the conversation is, you know, I think there's a lot of interest in measuring SDH at a managed care level, potentially paying on it, and asking that the plans and their contractors to put risk in it and to come up with innovative solutions on their own when they're in a value-based payment model. That's where we were going as a state. I think COVID has certainly changed the conversation. I myself am interested to see where we land after this pandemic is over. I'm not sure we all know. The other thing we're working on is we're an INC model, the Integrated Care for Kids model. And we're in that, we are also looking very closely at how do we measure SDH, you know, for kids on Medicaid and for communities, and how do we pay on that potentially in an alternative payment model. I have no answer. I don't have an answer. I'm reflecting back to the graph and what I see, and acknowledging there is a lot of gray area. And also I think maybe it was even clearer where we were when we were still in DSRIP. And then when we didn't get the second waiver, and certainly with the new administration, that's all to go up again. I am sure. No, I'm not the ultimate decision maker there currently, even what the application says, but I'm sure there will be changes in our approach.
Hello, Ma, this is Diana. I have a follow-up question for you.
Yeah.
You know, have you guys, you know, I'm sure you've been thinking about this, discussing, but what would it look like to measure MCOs, you know, on SDOH? Just, I'm thinking about all of the, you know, varying things, and that, you know, that stat that always sits in my head, which is, you know, people are an MCO member for 9 months. So what does that look like for New York?
And maybe I'll backtrack and say, like, my job is, like, I am the quality measure. You know, I'm the director of the Bureau of Quality Measurement. So I push out all the quality measures for all the plans. And so I'm, you know, supposed to be thinking about measurement. And you know, we look to our HEDIS measures, and we look to these standards of doing it. And we've long sort of thought, okay, well, it'll just have to be a process measure. It'll just have to be, were they screened or not? That would be the simplest starting point. I'm not saying it's a bad thing. We don't have it now, so it would be an improvement, right? And it could be as simple as saying, yes, there was a screener, and we're getting that through qualified entity data, or we're getting it through a Z code. So, like, say they attach a Z code that says they were screened for food insecurity, that would count, even though that's not a comprehensive screen. It would still show that there was some screening done. So, you know, I've thought about that. And then I think there's lots of people within even my own department would say it is not worth it to do unless we're going to get an outcome of the screen. That there was follow-up completed after the screen. And Medicaid, my colleagues in Medicaid have said that they are interested in finding that out. We have done also surveys where we asked plans what they do. No plans are really doing it. It's not like a formal model. So yeah, I think it would just be to acknowledge whether or not there is a screen completed would be the bare minimum first step goal.
Yeah, in Massachusetts, we actually, in our ACO measure slate, we have an HRSN screening measure. And so it's tied to shared savings, shared losses. Right now, it is a chart-based measure, which is, it has its challenges. But when ACOs report to us, if members have identified as having a need in 4 core domains, housing, nutrition, transportation, and utilities, then the results of those screens need to be included in the chart review submission. We do ask for other optional, or not optional, but additional supplemental domains. But I was just having a conversation today of, is there a way for us to convert that measure from a chart review measure to like a Z code based measure? But no one uses the codes right now. Yeah, it would be easier, but I think the work that would be needed to get increased uptake for those codes is just a very large lift. That for housing, we actually are maybe a little bit more successful because we include the housing Z codes in our risk adjustment for payment. So there is more incentive there, but we need to think through what are the other levers besides inclusion in a risk adjustment algorithm to get increased uptake, because we're not paying for the codes necessarily.
And Gary, quick question for you. We do something, we actually also risk adjust our payments to the MCOs based on coding for homelessness by Z codes, and intentionally chose that over other more robust data that we have from DSHS on housing, just because it's associated with a higher risk null. And I'm just curious on those other measures, do you have an understanding of like what the impact of reporting burden is on patients? I'm just curious, you know, I think I read this article in the New York Times about how good you have to be at paperwork to be poor in America, and just like all these different forms that people are filling out for eligibility for various programs. And I'm just thinking about the impact on the individual. You know, we've heard of cases, for example, where our MCOs are already doing screens, and if an individual reports a sensitive bit of information, like I'm having a behavioral health crisis, and and someone doesn't respond, then that kind of diminishes the level of trust that they have in revealing something like that more sensitive information. But yeah, how do you navigate some of those dynamics?
Yeah, it's a good question. I don't think we have the perfect solution here. But what we do say is on an annual basis, all of our ACO members need to be screened for HRSN, health-related social needs. And that feels right. I mean, because these conditions, they can change many times in the course of a year. So at a minimum, that felt okay. I will say the performance of our ACOs on this measure is pretty abysmal. It's in the teens. So that just gives you like a sense of where we are. It is a new program though. So we've implemented this requirement in the last, we're kicking off year 4 right now. Yes, year 4, that's right. So that's not to be unexpected. There's a reason why we put the requirement in place. We're starting from sort of a low baseline. We need to work our way up. But as it stands right now, patient reporting burden we're not seeing high enough screening rates for this kind of metric where we would be concerned about that. We want more reporting.
Let's, I want to make sure we stay on track here. So let's move on to the next speaker here. I know we want to jump in a little bit deeper. We've heard a lot about North Carolina here. So Amanda Van Vliet is here. So Amanda, let's pull up your stuff. And then again, you know, jump in here if you have questions for Amanda as she goes through.
Thank you so much. And thank you so much for having me today. I'm really excited to be here with this great group. I'm learning so much from the other states that are here also. So thank you all for your contributions so far, and completely agree. Please feel free to jump in and ask questions as we go. But I'll speak today a little bit about North Carolina's work in the SDOH space, and talk a little bit about kind of some broad overarching strategies that we have across the state, as well as some targeted initiatives that we have, the main one being our Healthy Opportunities pilots, and then how we leverage the pilots to create a program specifically for COVID-19 and people who are in isolation or quarantine for because of COVID-19. Next slide, please. Great, thanks. This is an intro to social needs in North Carolina. So North Carolina has about 10.5 million residents. About a tenth or over 1 million can't find affordable housing. We have the 8th highest rate of food insecurity in the country. Almost half of North Carolina women have experienced intimate partner violence, which is awful. And nearly a quarter of North Carolina children have experienced ACEs, as well as that there are many, mostly very rural areas of the state. So there are lacks of transportation access throughout the state as well. So that's some of the need in the state that we're trying to address. Next slide, please. Thank you. So we have focused on really building multiple ways of trying to address social needs in our state. So the North Carolina Department of Health and Human Services, we have within DHHS, we have Medicaid, public health, we have our social services, we have I know I'm leaving things out, but we have a lot all under one roof, and so we're able to coordinate and do a lot, which has been incredible. And including we have an Office of Healthy Opportunities, which is our term for social drivers of health, stemming from the belief that we think that all North Carolinians should have the opportunity for health. So we developed the certain initiatives and resources that are meant to be used for multiple populations and multiple initiatives across the state. And those are really meant to span across payer populations, for example. So those are things such as we have, and I'll go over these in a bit more detail, but we have an SDOH hotspot map. We do use a set of standardized SDOH screening questions. We use a United platform that we call Insecure 360. We are working on workforce development issues, and we're doing a cross-divisional effort on COVID-19 isolation and quarantine support. So those are all resources that that the state has created to address SDOH that can be used for Medicaid enrollees, Medicare enrollees, commercially insured, uninsured, anyone. And then in addition, we have a couple of targeted initiatives. Our main one, well, I'll say this in two ways. First of all, we're taking the shared assets that we built to use for all North Carolinians, and we're embedding them in our Medicaid managed care program as we transition. So we're using our policy lever as the state and our Medicaid program to make sure that our MCOs or our PHPs use these resources that we've created for Medicaid, and that will embed them in health plans, and then it'll get providers using them, and so then they're also, we hope, more likely to use them for their other patient populations as well. And then our most focused initiative is our Healthy Opportunities pilot, in which we're trying to get really specific and looking at if Medicaid dollars, we're looking at using Medicaid dollars to pay for social services and seeing the impact of that on our Medicaid beneficiaries' health outcomes and our Medicaid costs. And that we're really, I'll get into this a bit more, but we're really trying to look at very specific services for very specific populations to try to improve the evidence base in the SDOH space. So just a little overview of how we're trying to approach social needs through a variety of different avenues. Next slide, please. Great. So this is one of our statewide resources. It's a GIS map that uses census data. We work with our State Center for Health Statistics to map out a variety of social indicators throughout North Carolina. So you can see here some of the things we map related to education, housing, poverty, employment, insurance status. And so this is a resource that's publicly available on our website that anyone who is interested in trying to address social needs, whether it be our health plans or the state or community-based organizations, can go online and look to see what the particular needs are in specific areas of the state. Next slide. Thank you. This is a snapshot of the standardized SDOH screening tool that we use. So we developed a technical advisory group. We brought together a technical advisory group that helped us to develop a standardized set of SDOH screening questions to use throughout the state. I do think we were in a unique situation, I think, because while some providers were screening for SDOH, there was definitely in North Carolina at least not one standardized tool being used. And we haven't had managed care yet. We're about to launch in July. And so our health plans weren't using a standard tool for Medicaid beneficiaries. And so we really had the opportunity to implement standardized screening questions from the beginning. So we brought together this technical advisory group to help us draft this screener. And we took evidence-based tools and then basically selected questions from those evidence-based tools based on our priority domains. And we have 4 of those priority domains. We look at housing, food, transportation, and interpersonal safety. And then we try to simplify those questions from the evidence-based tools into simple yes/no answers. We were really trying to make the tool user-friendly so that it was easy to administer and easy to answer. So that was a primary goal. So then we released the screening tool for public comment. We field tested it in 18 clinical sites, and then we released it to the public in January of 2019. And so we do have some providers that are using the screening tool now, and our health plans will have to use it and manage care for our Medicaid beneficiaries. So we're trying to think about a way of uniformly collecting data on social needs in the state. Next slide, please. Thank you. So this is an overview of our Unitas platform and Secure 360. Many of you are probably familiar with Unitas platforms, and if not, it is an integrated online and telephonic tool that is a referral tool. It basically serves three primary purposes. One is an aggregator of primarily social, and we're also trying to incorporate healthcare, so healthcare and social services throughout the state. So it's really supposed to be a technological link between the healthcare sector and the human service sector. And so it serves as a resource directory of community-based organizations in the states and healthcare organizations in the states. And then it serves as a referral platform. So a care manager, for example, if they're seeing someone with food insecurity, they can send an electronic referral they can look up a food bank, for example, in the member's neighborhood, send an electronic referral through the platform, and then the food bank and all community-based organizations, when they are onboarded onto the platform, they receive a training. So they're trained to go on and then close the loop on that referral to say, yes, this person did in fact receive food services. So then the care manager can close the loop on those referrals and see if their patients actually did get food or not, and if not, why not, and they can follow up. So it allows care managers to do more comprehensive care management, I think, of social needs. So we are working with a variety of partners to implement this across the state, and it actually was supposed to, it was in half of North Carolina counties at the end of last year, and then it was supposed to be statewide by the end of this year, I believe, and we rolled it out across the state 6 months early, actually, to try to address COVID, to help people get connected to the resources that they were needing during COVID. So it is statewide now. So it's available in some community-based organizations, for example, all across the state, but we're still trying to deepen the number of organizations that are on the platform throughout the state. So we're still working on that. Next slide, please. Great, thanks. And the other statewide resource infrastructure that I'll mention is we're really working on workforce development. So we have a couple of different community health worker initiatives primarily that are working to create a certification program for community health workers, and then really find ways of connecting them to the healthcare sector and the social service sector. So we're encouraging our health plans to have community health workers as well as peer supports as part of their care management team and managed care, but are broadly thinking about this workforce development piece as well. Next slide, please. Thank you. So again, we took these shared resources and infrastructures that we were building and tried to embed them in Medicaid managed care. We're launching in July, so we'll see how it goes, but we're really excited about it. So for example, for care management for Medicaid beneficiaries, our health plans are required to use our standardized screening questions. And then once they screen and get information on social needs from those members, they use Secure 360 to connect those members to places where they can get support in the community. And then we're working on the workforce development to make sure that there are people who are able to serve those beneficiaries from both the healthcare and the human services side. And part of how we're trying to boost the human services side is through our Healthy Opportunities pilots by creating a constant funding source that's a bit more known in advance to CBOs in the community rather than solely relying on grant funding. So that's really the targeted initiative that I'll go into. We also offer incentives to our health plans for making monetary contributions to to health-related resources in the community. So investing in SDOH in the community. And if they do that, then they can count those dollars in the numerator of their MLR, and they may also get a boost in auto enrollment. And so they can use our hotspot map to try to figure out how they really target their contributions in the community. Next slide, please. Thank you. So I'm biased, but I think that this is the most exciting thing that we're doing in the state. It's our targeted initiative where we try to pull all of these things together and in a really focused way to try to build the evidence base in SDOH in North Carolina. So on the left, you'll see this is what an example of a local healthy opportunity pilot will look like in one region of the state. We've said that we'll have up to 3 of these pilot regions, so you could do this up to 3 times in areas of the state of North Carolina. So we got authority through our 1115 Medicaid demonstration waiver, where we can spend up to $650 million in state and federal Medicaid funding to fund pilot services that pay for social needs. And we've gotten quite broad authority to be able to fund things like first month's rent and security deposit, home delivered meals, medically tailored meals, fruit and vegetable prescriptions. We various transportation services, including public and private transportation reimbursement, where we can fund a variety of child and parent evidence-based courses and curriculums aimed at addressing interpersonal violence. And so we'll test how using Medicaid dollars to pay for these services impacts our beneficiaries' healthcare costs and health outcomes. So we're very excited about this. I think that we have found that there have been there are lots of programs to address SDOH throughout the country. I think that we're really interested in looking at how very specific services affect very specific populations. So we're really thinking about, we call it a funnel of eligibility criteria. So to be eligible for the pilots, a person has to be in Medicaid managed care, and then they have to have both a physical or a behavioral health need and a social need. And the physical or behavioral health need is really targeted at the demographic group. So for example, adults will have to have 2 or more chronic conditions, for example, where a child could have asthma. And there's different eligibility criteria for pregnant women. And so there's those eligibility criteria. And then we have some service level eligibility criteria as well, where to be eligible for a particular service, member will need to meet quite specific eligibility criteria. So we're really trying to match what services work the best for which types of people, so we can think about which of these work best. And so once we complete our evaluation, hopefully we'll be able to see which services were the most effective, which were somewhat effective, which were not so effective, so that we can add to the evidence base in this area. That's a very high overview of the pilots, but I'm going to move on because I want to allow time for discussion. So can we go to the next slide, please? Thank you. So when COVID-19 hit, our entire department basically dropped everything that we were doing to try to address COVID, like I'm sure every state did. And so one of the things that we thought of was, well, we've done all this work on designing these healthy opportunities pilots. Can we use this general design to help people with COVID or who've been exposed to COVID? So we used the model of the Healthy Opportunities pilots and applied them to COVID using CARES Act dollars. And so we braided a few sources of federal CARES Act funding to fund this program. One of the sources of funding goes to directly funding community health workers in the community. And those really play kind of the role of the care manager in the pilots, where individuals who need to quarantine or isolate because of COVID-19 are referred to a community health worker. They're a trusted member of the community. They screen the person for any needs that they have to help them isolate or quarantine, and then they refer that person to resources through NC Care 360. And then we have a separate pot of CARES Act dollars that we've used to fund the support services program, which is the source of funding that we use to pay for select services. So we did an environmental scan basically to see what social supports people would need to isolate and quarantine, what was already covered, what needed to be covered. And we basically heard from the community too that the things that were most needed were home delivered meals and then financial assistance, frankly, to offset lost wages, if they had to stay home for a couple of weeks and they didn't have paid time off, or to afford childcare if they couldn't afford it while they had to isolate or quarantine. So those are two of the big services. We're also offering some transportation services, home delivered medications, and COVID supplies, like cleaning supplies and thermometers and cleaning supplies for home. So those vendors are, most of them are, one is a health system, the others are very small community-based organizations or smaller health clinics that are partnering with other CBOs to help deliver those services to people who are in isolation and quarantine. And then the third funding source is actually not CARES Act dollars, it's FEMA dollars, but it's we get FEMA reimbursement to help stand up non-congregate shelters to help people isolate and quarantine as well. So we've kind of braided these funding sources together to create one big program that looks like the Healthy Opportunities pilot. And it is going very well, I would say. It was rapid fire and hard to stand up very quickly, but I think the response that we've gotten from the community is pretty overwhelmingly positive, where I think that people are being impacted a lot by these services. We just got some new numbers. We started the program in September, and we've delivered about 90,000 services to over 21,000 households in 29 counties of the state. So we're pretty proud of it, and we're also learning a lot of implementation issues, successes, opportunities, and also hurdles that we're facing that will really help us as we think about implementing our Healthy Opportunities pilots. So that's where we are, and I'm sure that things will continue to change and evolve as the pandemic changes and as we move into managed care and as our Healthy Opportunities pilots start. But we're really excited about the work that we're doing. So happy to take any questions.
Great, thank you so much, Amanda. Let's hear from folks here. Questions? You've done a lot of work there, definitely. So other states, if we could hear from you.
I've been talking a lot, but if no one else
That's
is going to
okay,
go.
we like that.
Thanks for sharing that, Amanda. For the evaluation piece that you were talking about, are you guys thinking about having the plans identify metrics themselves, or are you guys standardizing the metrics so that you can compare across programs? I think one of the things that has been really challenging for us, as some of you may know, we were delayed in launching our flexible services program, which is how we funnel the Medicaid dollars to housing supports and nutrition supports. So we've just completed our first year, And we did not require standardized evaluation metrics because all the programs are different. We give pretty broad flexibility for what populations you can target, what are the actual services that are offered. So basically giving people a menu to choose from. And so because of that, we felt like it would have been challenging to pick A1C levels as a metric when the population isn't a diabetic population. So because of that, we are finding it, not surprisingly, challenging to come up with any sort of insights that span the program. Yes, our independent evaluator will be looking at things, but there's going to be a significant time lag there. So just wanted to see if you guys had any thoughts about that. And yeah.
Yeah, that's a really good question. We are also using an independent evaluator, and they defined the metrics as standard metrics that we would be using. So we'll be looking at healthcare utilization, healthcare costs, and then some specific health indicators per per like age group or like adults, children, pregnant women. So they did define standard metrics. We had those luckily in advance as we were thinking through like the design and the services that we're creating. So I think that was helpful to have earlier on.
Paloma, did you have a comment? I wasn't sure if you had your hand up or we're just.
No, I'm sorry. I'm like having the afternoon yawns. No, I mean, I always have something to say, so I'm glad you called on me. I think, I mean, it's so interesting to hear, and it's like, oh, pangs of jealousy. It's like, well, it sounds like that was really easy for you to like get an SDOH program. I mean, like it's not, but I think I think it's like fair to say you were in a unique position, pre-managed care, and you had some things in place that made it doable. And like, that's, and I shouldn't get jealous because you're an example to other states. Just because we're off in our own world in New York doesn't mean that we can't like look for your state for lessons. And I think, and I'm also like, wow, I have to reflect, like, why didn't, we see some of this, sort of immediate transition to some programming? And I was like, because New York State, we were just really hit hard in March and April, and we were just all hands on deck for actual COVID response, So I think this is a great example, actually, like with emergency response for Medicaid agencies. Like if you're looking at this, like, okay, who can act and who can leverage on the current status quo, and who can. And I think it's a really kind of a fascinating real life policy experiment that shows like innovation and the ability to like leverage, as I can imagine, really hard work with your stakeholders and like lots of meetings and lots of hand holding. So really kudos. Yeah.
Thank you. Thank you. I appreciate that. It's been really interesting. I feel like we talk and get really excited about doing our pilots. And so to actually be implementing a COVID program has been really interesting to see how it's actually working day to day. And I mean, we're working with pretty small organizations, and I'm hoping our lead pilot entities will be a bit more sophisticated, but we found things like they don't have enough upfront funding to be able to provide financial support to people, and we can only reimburse retrospectively. And so these issues that we come up with of like, how do we find a way to pay them in advance so that they can deliver services to people, and like certain infrastructure needs that they have that we weren't expecting. It's told us that a couple of our reimbursement rates have been kind of low to fund completely for services. And so it's been a really good learning experience. It's, just been surprising in a lot of ways, but we're learning a lot.
Yeah. And we had a big independent evaluation for DSRIP. It's finishing up now. And I think of another thing for the folks on the group and for us to think about is like how to take those lessons that are really, as you know, Melinda, you're reading these reports are really buried in these independent evaluations, and share them in ways that are readable in our real lives. I think it's a real challenge. So we're not just repeating the same things over and over again and failing.
Can I offer two kind of thoughts that for people to react to, and these may be controversial. One is I think one of the approaches in North Carolina, while there are a lot of interventions, there are really clear criteria on we are prioritizing these populations and these interventions. And I know other states have said, we're going to delegate that down because we want that to be authentic. We want to let it bubble up from the community. I'm going to say my bias is for the former. I feel like getting your toehold in on some common populations and common interventions and common measures that you're going for, and then expanding from there, giving enough flexibility within that to have some choices. But my hypothesis is in that states who have been too broad, they've struggled to create momentum, and they've struggled to give enough resources to the infrastructure to go to scale. So that's one hypothesis. And then the second one is for states, there's a focus on ROI and there's a focus on improving health. And for states who are exclusively focused on ROI, that's too high of a bar. That improving health itself is a purpose of your Medicaid program and your CHIP program. And so structuring your programs only around ROI is setting yourself up for failure, and that there needs to be measures in there that is weighing both of those things and assigning value to both of those things in order for you to be able to move to scale. I know that that's easier said than done in environments where state budgets are under unprecedented pressure, but let me just throw those two ideas out and see if folks have reactions.
Yeah, so as Massachusetts, we're one of the states. Well, I guess it depends on how you define the select populations or the select services. So did you all identify almost predefined programs like this? If you want to offer pre-tenancy supports, these are the certain health conditions that would work, and it's like high blood pressure, like heart disease, or was it this is a list of conditions, health needs-based criteria that work, and you can pick from within those populations to identify your specific target population. And then same thing with the services. Like, did you say you have to have these sets of services together as a package, or is it more of like a menu approach? You can pick from these various interventions.
Yeah, that's a good question. And Melinda, please feel free to weigh in here if you'd like. We set the criteria. So we tried to go deeper into what you were talking about setting like A1C levels or something for like very specific services. And frankly, we found that like there just wasn't enough research on that for us to be able to draw any conclusions. I don't know if others have been more successful than we have in finding that. So it's not that detailed, but it is, we made an effort to focus on what we thought would be the highest need populations, kind of in each demographic category. And then within that, if in specific services, we thought, well, I'm trying to think of a good example and I can't, but what specific criteria would be needed within those without getting to such a level of detail that we thought it may prohibit the evaluation to be more specific upfront, and two, that like the evidence just didn't exist yet. So it's in between, I would say.
I'm going to hit pause on this conversation because I want to make sure we have time to get to Robert, who's going to talk about not from the state level, but doing this, looking at federal programs across the board. So I want to make sure we get a chance to, Robert Bussark, let's get to your stuff here.
Yeah, thanks for that.
Yeah.
I want to start off with a qualifier and just a quick observation. So the qualifier is, it was mentioned earlier that I work with the Department of Veterans Affairs. That's true. I've worked with a couple of federal agencies, but I'm here just as me. So this is not a position or anything like that.
Most of us are here just as us.
Yeah. And the second is, I'm old, so this reference may only make sense to me, but I sometimes feel like a Monty Python skit where they would occasionally interject it and say, and now for something completely different. So I appreciate all the presenters and I'm really actually grateful to be included with all of you. I feel very unqualified and a little bit of a slacker in my life listening to all the work you do. So thanks for letting me listen. You know, I'm a suicide prevention researcher, and so I put together some slides because I felt like it was the thing to do. I don't know how useful they're going to be though. So I'd like to just talk a little bit about what the point of all of this is. So I use data very differently than I think most of you use data. I'm a psychiatric epidemiologist by trade. I spend a lot of time trying to figure out who's at risk for suicide, which has sort of been the practice for a while. And like many of you, I'm limited in the data that I have available to do this. And so what we traditionally rely upon, as I've heard many of you say, is the preponderance of clinical data that we may have on a person, diagnoses and health services they use and what medications they get, and those things that ultimately drive risk. But we know those are inadequate. They're, you know, to use the, I guess, played out phrase a little bit, they're necessary but not sufficient to understand who could be at risk for something. And so for quite some time, there's been broad recognition that social determinants of health play a large role in mental health crises and adverse outcomes of all forms. Not just what it might mean for a person's lived experiences, but those resources available to them in their environment and how those things may interact to increase or decrease the probability of a poor outcome. And so the availability of information on social determinants of health offers great promise for the potential to improve our ability to identify people at increased risk for suicide or other adverse outcomes. And I throw other out there because we're also doing similar work trying to understand people who are seeking treatment for opioid use disorders and other substance use problems, and how can we put them in the best position possible to be successful. And if you wouldn't mind, perhaps you could just advance a couple of slides. I have a couple of bad graphs, which is what, yeah, there's one. This is what happens when you let a psychiatric epidemiologist do graphic design. It comes up with green and red dots on a blue background. So I think this is the more important of the two. Recently, there's been a lot of activity in the space, and it's activity that I think that I do that's like this that's led to the invitation for me to speak with you all today. Risk prediction has become very popular, and you'll see manuscript after manuscript or report after report where people are trying to do this. The previous graph sort of showed these little red dots, which would be people at risk sort of scattered around the population, the larger population. And we do this whether it's at a population level or individual level, right? We try to find those hot spots where people have something in common we think we can address, and we try to direct resources to those places. And so increasingly with the tools available to us and the analytic approaches available to us, we've begun trying to figure out better ways to do what we call risk concentration, right? Can we find ways to consolidate the grouping of populations at risk or people at risk to allow for targeted interventions? So we're limiting where we're trying to disperse our resources, concentrate them on a specific population, and that's currently where we've landed. And so there are a number of exercises out there where they go out and they generate predicted risk scores for suicide and other things, and they go off and they do something about it. The problem is that's destined to fail. And where I think the availability of some of these data and perhaps a more nuanced way of thinking about this may in fact offer great promise. Simply generating a predicted risk score tells you nothing more than the fact that something's likely to happen, but it doesn't tell you at all why it's happening or what in the world you could possibly do about it. And so if all we're really interested in is understanding who's likely to crash their car into a tree or die by suicide, all we really know is how many times we fail to stop it. We don't really know whether we've gotten any better at doing anything about it. So from the beginning, as we've been doing this as both a public health practitioner and academic exercise, the concern I've had is that our ability to more appropriately or more accurately identify who's at risk without inter-county effort to try to prevent that thing from happening or any consideration of how we can prevent that from happening just means that we fail more often. It doesn't mean that we necessarily have done anything good. It's just that we've identified more people for whom we stop that event from happening. And that feels like a wholly inadequate enterprise. So part of why we were so excited about the opportunity and we're working with LexisNexis and we've obtained the data and we're beginning to model those data now, to introduce some of these social determinants of health information or data is specifically for that reason. I don't think the question should be, can we identify people who have a high probability of having a negative event happen to them, whether that be a suicide attempt or being a victim of interpersonal violence or something else? It's, can we identify a period of risk for an adverse outcome that's happening for which we have a solution that we can direct resources to try to prevent or lessen the probability that's going to happen? And that needs to be done in a nuanced way. So when we think about social determinants of health and where their promise is, many of the solutions that come to mind are the ones that I've heard today, and it's the direction of resources at an upstream level to try to prevent something from happening downstream. The promise of what we're trying to do here with predictive analytics is, I guess in that same vein, we're trying to identify people who have a high probability of having something happen that gives us an opportunity to act before that thing actually is realized. The problem is the gap between the probability that something's going to happen and that thing happening is often so short when you're thinking about something like suicide prevention that upstream interventions that require large systemic change don't have the opportunity to have an effect. So one of the things that we struggle with are not only can we find indicators of things that are going to happen, but are those data available in a timely enough way that we can use them to be an to provide an opportunity for intervention between that elevation of risk and the realization of that event? Can we also have a solution informed by those data that will yield an immediate return or a short-term return in a reduction of risk that doesn't require a system-level process or longer periods of time for that to play out? So as we work our way through these data and begin to think about how they may inform what we're trying to do by suicide prevention, these are some of the issues that we're grappling with. Not only do they improve our precision, in fact, one of the things I thought I might argue here and that I've been arguing recently is these exercises that you hear about better and better data at predicting who's at risk for something. I think we've sort of saturated the benefit we're going to get from those, right? I recently wrote a position piece for the American Journal of Epidemiology that asked me to comment on models for predicting risk for suicide. And I pretty much said, I think we've had enough of, this is the first time we've done it in this population, or the first time we've done it in that population. I think we've shown we can do this sort of thing. What we haven't shown is that we can do anything about it. And I think it's time that we start thinking about using these data to actually do something. And that requires a much more nuanced understanding of what's going on. So I'll give you an analogy that may or may not make any sense, but it might help frame how we're thinking about this in terms of suicide prevention. It's long been known that some disease states cause increased risk for suicide and other adverse outcomes. And so one that comes to mind immediately is cancer. And so cancer is a pretty well evidenced indicator of increased risk for self-harm, but it turns out that it's really not that simple, right? So it's not just any cancer, it's the type of cancer, and it's a time period around diagnosis, and it varies by cancer type. And even among those people with the highest risk of suicide and cancer, it's among people with lung cancer within 6 months of diagnosis. But it's not just lung cancer, as a matter of fact. It's bronchoalveolar lung cancer that is metastasized from another site. So even something that is as straightforward as a construct like, and I'll reflect back on one of the ones that was shown before, whether you own a home or how far your family, own a car, or how far your family is away from you, in isolation doesn't tell you very much about how that's playing out in that individual's experience or how that may come together to demonstrate risk. And so I made a few notes here that I think I'll just give to you all for consideration. And the one is about precision and predictive accuracy. I don't know if that necessarily needs to be improved upon much more. I think it's much more important to think about when there's a risk for something to begin to happen, rather than the probability that something happened. Can we identify a meaningful trigger that means a substantive change? And so what I look for in these data are change, not state. I'm looking for a change from one state to another that I think is incredibly important. The other is sort of definitions of social determinants of health. I think we use these quite broadly. I know this is a problem in the field overall, that we say social determinants of health, meaning a certain collection of constructs, but how those things are actually measured and what that means for actually doing something with it, I think is important. And I'll offer cancer. Oops, sorry about that. That's my miniature schnauzer. I'll offer cancer up as an example of that. It's not enough to know simply that a person lives in a neighborhood where there's poverty, because it's often not that absolute state that makes a difference. It's the relative state that makes a difference. One can live in Beverly Hills and live in the worst home in Beverly Hills and feel like you're ostracized from everyone else and not having necessarily the opportunities and resources to be available to other people. So it's not often the neighborhood that matters. It's the placement of an individual within a neighborhood, an individual within an environment, and the relative distance between those two that may matter more than the absolute value of something that's going on. I think the other thing that the point I wanted to make is simply that point about change. what we're looking for most often is change as a meaningful indicator of something going wrong. We're looking for aberration. We're not looking for a continued state. In some cases, a continued state in the placement of social, even with social determinants of health, can be an okay thing. It's change that could be bad, and it could be change upward or downward that could be bad. So, for example, a person that lives in a neighborhood that has poor access to healthcare, or low overall income, or poor access to healthy foods, may in fact have found ways to negate the effect of that if it's been present for a long time. What could be an indicator of something going wrong is a movement to a neighborhood where things are worse, or even possibly a movement to a neighborhood where things are better, where their individual position hasn't changed. So it's, I think, a little more complex than understanding the characteristics of a group. It's understanding position within group and changes across groups. I think that may be more important. And for me as an analyst, I think what that means is more understanding the interactions between things rather than the absolute value of things. Understanding where something differs for a population is meaning from other people. That's where things are important. And the last thing that I would just offer, and it's only because I've been sort of consumed with this and thinking about lately. So I do research. Unlike all of you, I don't represent systems that can do things for people and operate in a multi-level way. I operate as a person who takes information and tries to use it for something good, I hope. And there does become a question, and I can tell you that a lot of my colleagues and peers, it's interesting when I talk to people about the work I do, I'll get people that say, that's interesting, but should you be doing that? Right? There's always concern about use of information like this. And it's a question I don't think should be discarded. So all of you represent different agencies of some type, and I think there is a question that should be asked about, is there a reasonable expectation on the part of the person whose data ultimately that experience belongs to, that the agency would be using or have access to that information? And it's an interesting point, because I think not only does it have an impact potentially on the sustainability of the program, but I think it also has a potential to impact the willingness or the effect that willingness of the person to engage in whatever we're offering, as well as the ability of that program to have an effect. And I'll give you a specific example because it may not have been clear. So the work that I do is more clinically oriented, and I try to make recommendations to clinicians and clinical systems about what they can do to stop something. So if I have access as a researcher who represents a health system, and I'll use West Virginia University Medicine as an example, if I have data on a person's arrest history, and and I happen to know that they were just arrested for a violent crime in a particular neighborhood, and I know that given their psychological profile, this might be a meaningful escalation of their suicide risk. If I act on that information, that individual now knows that the health system is scouring through their arrest records, even if that information is theoretically and legally and morally available to me, is it going to create a disincentive to engage in the future on the person that I'm reaching out to? So at some level, I think for my side of the world where we do research, I think it's important to have conversations about, and by research, I didn't mean that you're all not doing research, but I mean strictly academic, not tied necessarily to a system research. Is there an obligation on the part of the researcher or the system to acknowledge that we're accessing this information before we act on it? And I think that's more of an ethical consideration than it is anything else. I'm not sure there's a good answer, but I felt like I should raise it anyway, because I'm sure all of you have thought more about this than I have and probably have better answers. But it does tie into this question about ownership of data and ownership of information, even if it is public records information, and the ability or willingness to act on that information, even if the intended use is to improve a person's outcomes. And I think that's it. I think those are my most controversial notes. The last thing I would just note, and you'll forgive me for these comments, some of them may not have made sense. Hopefully some of them did. Some of them may have been poorly thought through, but that's me. I like to throw things out there and see what happens. I suppose the last thing would be to say, my deepest hope is that we can move away from sort of predicting what's going to happen to a person and starting to predict how we can stop it. It's not just trying to say that something bad is going to happen to a person. It's that we can offer up a solution that will prevent that thing from happening or lessen the probability that it's going to happen that's individualized, so that we're making individualized treatment recommendations, individualized program recommendations that increase the potential impact of that outcome, of that intervention or program on the individual for whom we're trying to enroll in those programs. And I think that's easier in some of the programs I do where there's a direct clinical medicine component of it that it is on a population health level. But I think both are possible. And if you don't know the programs and haven't looked at them, there's this amazing group out of Houston, Texas called Predict, Align, Prevent. And they're doing this at a community level. And they're sort of taking the machine learning, individualized algorithms we're doing for personalized clinical outcomes, and they're applying them to communities. And they're taking data to begin to predict where communities are likely to have an event happen. So for example, it started with gunshot wounds among youth to predict the next neighborhood with the highest probability of gun violence. And then they're simulating different interventions and the effect those interventions would have on the community to identify the solution that's most likely to reduce the probability of gun violence in that particular neighborhood. And I think that analogy is a good one. It's what we're trying to do on the individual level, but it's also possible on the community level. So I think there are parallel opportunities here. And I think that's it. The rest of the slides you guys can have, I'm happy to talk about them if you like, but they're really not that interesting, I don't think, for me.
Thank you, Robert. I really appreciate you kind of targeting your comments there to the conversation. I mean, this is great. Really helpful, really interesting. Questions for Robert?
Robert, this is Karen from Illinois, the Illinois Department of Public Health. In the Office of Health Promotion, the suicide prevention efforts are housed. So I was really looking forward to your presentation. A couple of takeaways I really like are you're emphasizing change versus, like state. And really, we're looking more at population-based outcomes for suicide, so we're not looking clinically.
Right.
And obviously, those are different implications. We're talking, youth, veterans, and you're talking a little bit about changing the mindset in terms of how you look at suicide. What kind of recommendations would you then provide for population-based efforts that are more larger efforts with relation to suicide?
Yeah. So I think both are, that's why I tried to offer that Predict, Align, Prevent example. I'm not sure that, I think the input data are different, but I'm not sure that the overall theoretical orientation or goals are all that different. Mm-hmm. Change at a population level happens more slowly, right? Mm-hmm. But you can, if you think about populations, rather than change certainly can be a factor, but composition and case mix can be a factor that you can equate. So maybe the change isn't in the larger values of, say, overall income. But it could be in the occupation groups or income disparity within the population that matters more. Mm-hmm. We all know at an aggregate level, the average is exactly that. Doesn't mean it's not hiding a greater increase in disparity in the population. If you have a small number of people with increasing income or a bigger number of people with decreasing income, you can still have the same average, right? So I'm not exactly sure that I would recommend any difference at all. I think it's in a way you think about the data that you have on hand. The way you think about how those data could best be used in whatever functional form mm-hmm. is going to differ varying on the level of analysis you're doing. But I don't think it's different, actually.
Yeah. Well, I think that it's very informative because we have a team of epidemiologists that's going to be looking at suicide, violence prevention, opioid use, a lot of this intersectionality with coexisting, behaviors, lifestyle patterns. So I really like what you're bringing to the table in terms of an example of a program that's looking more at, like what can we actually do about it in terms of that instead of, like prevention. Right. But very helpful, very useful information. Thank you.
Kate, I know this is your area, so it'd be great if you want to jump in here.
Yes, and unfortunately, I have to drop off the call to join another call. I actually just sent a message to everybody, so my apologies. I'm really fascinated with some of the work that you're doing on suicide prevention, and a lot of what you have to say are some of the challenges that we're trying to problem solve. And if anybody has ideas about how that could best be accomplished, we're open to that. We're looking for creative solutions, and it is difficult to apply what we know works individually to a population in a rapid kind of way, right? So it's got to be small gains over time, and we have to address the larger system, data collection, research, how it's conducted. The whole system has to have basically a paradigm shift, and that's what we're working towards. So I'm so sorry that I have to drop off, and thank you so much for the invitation.
No, thank you.
All right, take care.
Yeah. I think this is a really critical issue most states are working on. So any other comments or questions? I know there's a lot more people here than we can see on camera, so we know you're there. If you want to just speak up, that'd be great.
I just want to say thank you for this. It was very interesting to hear all of the strategies that were presented. My name's Tamara Litwin, and I'm an epidemiologist with the National Institutes of Health's All of Us research program. So we're more of a research-oriented organization, but we are interested in learning about the social determinants of health of our participants, mostly via survey modules. But it's very interesting to hear how that's being collected in the various states. And so thank you all. I know I was mostly a wallflower, but I appreciate it.
That's okay. We welcome everybody here. Great. Well, I just want to, I know we are pretty much at the top of the hour here. I do want to thank everybody for joining today. We're going to send out, or One-A will send out a list of kind of resources. We'll send out links to a number of the reports today, to the slides that you got today. As I mentioned, we are going to be working on kind of a summary brief or report of everything that was presented today. So you'll get that probably not for a few weeks. But we're going to send you a link. And then if it's also okay, I'd be happy to share some of the contact information for the different states. I think that would be really helpful for you to each be able to be in touch with each other. We want to encourage that as much as possible, collaboration between the states and sharing. And so please, we'll go ahead and send that out. Thanks for those of you who were able to stay on. We've got about 20 something people who stayed on to the end here, so I appreciate that today. And wish we had more time. We are going to continue to do, again, this is a really critical area for our organization, so we'll continue to convene these types of meetings. And if you have specific thoughts about kind of the focus for some of this state work, you know, should we do a whole session on suicide? Should we do a whole session on some of these? I mean, I would appreciate any thoughts or comments. You want to shoot me an email or One-A and let us know, because, you know, we're really here, again, we're a nonprofit to support the important work that you are doing out in the field. You guys are doing great work and we appreciate all your efforts. I know sometimes being a state employee is not the easiest thing, but we appreciate everything that you're doing and we recognize that it's a really noble cause and